name's Drew Holzoffel, and I will be moderating today's conversation. Today we're going to hear from experts about the growing impact of Alzheimer's disease. Specifically, we're going to hear new research on the number of people living with the early stages of Alzheimer's disease. We'll discuss why these better estimates of the number of people with Alzheimer's disease by stage are important. This work is supported by PAVE. PAVE stands for Project Alzheimer's Value Europe, and it's a consortium of organizations created to increase collaboration and understanding between key stakeholders, including regulators, bodies responsible for health technology assessments, payers, clinicians, patient advocates, and industry. To start our discussion, I'd like to introduce Weija van der Pleer and Anders Gustafsson to walk through this new analysis. Weija is a professor of neurology at Amsterdam University Medical Center. Her focus is on bringing personalized medicine to Alzheimer's disease. And Anders is a professor at Karolinska Institute in Sweden and co-founder of Quantify Research. Over to you two, please.
Thank you, Drew. It's my pleasure to talk to you today about the global estimates on the number of persons across the Alzheimer's continuum. And earlier this year, as the PAVE project group, we published this article in Alzheimer's and Dementia. We're going to share the contents, the summary of the contents with you today. Across the world, over 55 million of patients suffer from dementia in 2000. These are estimates of 2019. And the most recent estimates for Europe are that there were in 2018, 9 million patients with dementia. And there's an expected increase of over almost threefold to 140 million in 2050. Most of the patients with Alzheimer's disease, with dementia, suffer from underlying Alzheimer's disease, with an estimated 26 million globally in 2006, which was projected to increase to almost 110 million by 2050, and 17 million in Europe alone. And this disease is associated with an enormous large burden in terms of costs, because the costs associated with dementia are estimated at $1.3 trillion and still increasing. And in Europe, only $430 billion are estimated. So important to note is that most of these diagnoses of Alzheimer's disease have not been confirmed by biomarkers. So we do not actually know whether it's Alzheimer's disease or another type of dementia. And second, while we now know that Alzheimer's disease and other types of dementia develop in the course of years, even decades, the prevalence numbers only concern the dementia stage. And in fact, dementia is only the last stage of a disease, most of which, the largest part of which occurs before that stage of dementia. So in the dementia, you have the dementia stage with mild dementia, moderate and severe dementia. And before that stage, there's the stage of prodromal Alzheimer's disease. And another word for that is mild cognitive impairments. Before mild cognitive impairments, brain changes already have started to occur for years in what we call preclinical Alzheimer's disease, which has a completely asymptomatic phase and also a stage of subjective cognitive decline that may be characterized by very subtle cognitive and/or behavioral changes perceived by the patient themselves only, or perhaps a family member. And I'd like to reiterate that when we talk about the numbers, the projected numbers for dementia and Alzheimer's disease, these estimates have not been confirmed by biomarkers, which is of course very relevant when we think about a future where we will have disease-modifying treatments. And in addition, when we think about this disease-modifying treatment that may be most effective in the stages before dementia, it's important to realize that the pre-dementia stages of Alzheimer's disease have not been included in the estimates on the size of the Alzheimer's population. And at this stage, I would like to hand over to Anders Gustafsson, who's going to share the results of the study.
Thank you very much, Weija. So our objective was to identify the available evidence on the prevalence across all stages of Alzheimer's continuum. and then to synthesize this evidence to produce estimates of the number of persons globally with on the AD continuum, and then a specific focus on some target populations for preventive measures and future therapies. So we performed a systematic review of the literature, and we involved a group of AD experts to look at this literature and decide on best estimates to develop these estimates of number of persons across the AD continuum. In reviewing the data, we found a handful of studies that were the best available sources for developing our model and estimate the number of persons. And you can see them here. And these are large-scale systematic reviews and meta-analysis of the available literature. So there's a ton of studies out there, original studies, and these publications have coalesced those studies and provided prevalence estimates based on those original studies. So the results, here you see a graph of the prevalence of A-beta positive Alzheimer's disease, so biomarker confirmed AD, across different age groups for men and for women. And you can see how it increases with age, as expected. And you can see that AD dementia is prevalent in higher ages, whereas the pre-dementia stages of AD, they start at earlier ages still. Other risk factors include low education, genetic variants like APOE, epsilon-4, allele carrier, and female sex, as well as ethnicity, primarily from American studies on ethnicity. There is limited evidence of the variation across countries, except for in general dementia. So this is a data gap where we need more studies. Looking at the number of persons based on these prevalence estimates and the size of the populations across different regions and countries, we could estimate this graph, again, with different age groups. And here you see a clear difference between men and women, especially in higher ages, where Alzheimer's disease is more common, where there are more women living with Alzheimer's disease today than men. And this is both because they're more numerous in the high ages, they have a higher life expectancy, but also, as some studies suggest, that there's a sex-specific risk of Alzheimer's disease in women that is higher than in men. You can also see here that there are large populations in younger ages due to, despite the low prevalence estimates, because there are many persons in these age groups due to demography. And here you have a summary of the results. The upper table, table 3, is for global, and we estimated a total of 416 million persons on the AD continuum globally. And the lower table, there you see European estimates for the larger Europe, where we find 75 million persons, and only 7 of these in Europe are on AD dementia. They constitute, on the full Alzheimer continuum, they constitute 22% of the population above 50 years of age on a global level, and even a bit higher in Europe. And the majority are women, and the most are in pre-dementia stages of AD, more than 9 out of 10 persons. And again, these are important targets for preventive measures. Back to you, Vishay.
Thanks. So what we see is that the majority of persons with Alzheimer's do not have dementia, but are in earlier stages of the disease. And we do need further studies to provide more precise prevalence estimates, and also better insight in risk factors and variations across countries, and also to know how these Alzheimer's continuum will develop clinically. So more than 2/3 of all persons on the Alzheimer's continuum have no measurable symptoms. So they're in preclinical AD stages and they can only be identified with biomarkers. And on the one hand, this does provide windows of opportunity for prevention. And it also shows the relevance of, for example, blood-based biomarkers that would be accessible and scalable for many to use. This information is of great importance to inform policymakers and healthcare planners on the size of the population that would potentially benefit from future therapies targeting AD pathology. And I think that's important to note that even when the largest part is in preclinical AD, these future therapies will primarily target prodromal AD and mild AD dementia. So not at this stage, not a preclinical AD stage. But we can also think about non-pharmacological prevention strategies, and they would be primarily eligible for preclinical AD stages. And this information is also of great importance to inform on the size of the population that would be eligible for more robust detection, timely diagnosis, and potentially in the future screening programs. And in that way, it's important because we are working towards a future with precision medicine for Alzheimer's disease.
Well, thank you very much. That was an excellent presentation. This is a really interesting study. What I'd like to do is bring in some additional points of view as we talk about the study and what these results mean. But before I introduce the rest of our panel, Weijia, I'd just like to ask you two quick questions. And the first one is, as you think about what we just heard, the question comes to my mind of what language should we be using when we describe Alzheimer's disease? How do you talk about this when you're talking to other experts in the field?
Well, Drew, I think that's really a very relevant question. And also when you think what would be the impact of these findings on a societal level? What does it mean in society? And what I tend to notice is that in society, dementia and Alzheimer's disease are still used more or less synonymously. So as they are the same. But what we see is that they're not the same, because Alzheimer's disease is a disease, the longest part of which takes place before dementia. And I think there's quite a fierce debate amongst professionals now, whether you should call the earlier stages disease or risk state. And actually, I think that should be solved by that we start to change the language, that Alzheimer's disease really refers to the pathology, the brain pathology, and that apart from that, we also have the clinical consequences, which may be dementia in the end, but before that, mild cognitive impairment or cognitive decline. And we need to disentangle those two. And another thing that's of quite relevance to realize here is that in this paper, we focused on Alzheimer's continuum. That means that we took amyloid positivity as a starting point. And when we think about Alzheimer's disease, you really need amyloid and tau positivity, which is far less common. These numbers are still very relevant. And again, this illustrates the necessity of this precise language. When we talk about Alzheimer's continuum, amyloid positivity, that's very relevant knowledge because you may be able to do something about that in the future. And that's something else in Alzheimer's disease, when you have both amyloid and tau, and that's also very relevant, less prevalent than amyloid positivity alone. So there's a lot of things to study still, but also relevant to discuss this in a more societal context about the prevalence of Alzheimer's disease, and that we also need to reduce the stigma because it just is very common.
Yeah, great points. One follow-up question here. As you think about how this study will inform how we intervene and, ideally even prevent the disease, what can we take away from this analysis that will inform those strategies?
Yeah, well, what I think that's very relevant is that you see that we now have the biomarkers to be able to identify people with amyloid pathology in their brain, with Alzheimer's pathology in their brain. So in the future, when we may have disease-modifying therapy, we can actually treat those who benefit. And I think it's very relevant to reiterate that when the disease-modifying therapy comes to society, to the market, that this will initially be to the clinical stages, not to the preclinical stages. But even so, preclinical Alzheimer's disease also has great relevance because actually The primary prevention strategies, for example, by intervening with lifestyle interventions, may still be helpful in these preclinical stages. So these also provide a window of opportunity.
Thank you for those important points. Anders, as we think about what these results mean, given your view and your understanding of health technology assessments and the important work around value assessment, one follow-up question for you is how might we consider costs of Alzheimer's diagnosis in future value assessments?
Yeah, thanks, Drew. It's a great question. I see this as a shift, right? We standard of care today is much about watch and wait because there's not that much you can do, especially in the earlier stages. And we see a lot of clinicians saying that they don't really want to tell their patients that they might be at elevated risk. But this might change once we have a disease-modifying treatment, right? And what we show here in this study is that the numbers are huge for those that could be eligible for treatment. And the costs associated with diagnosing them would also be huge then. And how does that affect the new intervention strategy? When we evaluate a first-in-class drug, and if that also means that we need to implement new diagnostics, then many assessors would like to include those costs in that strategy. And the comparator would be standard of care where you don't do anything, right? And you don't need those diagnostics. And this is tricky, I think, for both decision makers and for drug developers, how to view upon the future. Because it's not only the need for treatment decisions and drug treatments that drive the willingness and need for better diagnostics, but they are interlinked. So I think the investment costs in diagnostics and the shift towards more biomarkers, more screening, more cognitive testing, more of a thorough diagnostic workup, that will need to be considered when evaluating also the value of a new disease-modifying treatment.
Thank you for those important points, Anders. You know, as a patient advocate, this idea of watch and wait absolutely has to change. So thank you for making that point as well. It actually builds nicely into our next panelist. I'd like to bring Annie Chikoye into this conversation. Annie is a market access and health economics expert. She's a professor in Europe and in Asia as well. And so, Annie, if you listen to this presentation and you think about the results from your perspective, what will payers say to the results of this analysis?
Well, I think this information first is new in terms of investigating the preclinical and prodromal stage of the disease, and I think this is very, very useful for the payers in terms of clarifying what it is about to address Alzheimer's disease. Especially when we have those disease modifier treatment which are being developed and targeting this early stage population. In that sense, I think it's a very useful information that has been compiled, and congratulations to the authors, actually. That's really, I think it should be looked at very carefully, although we have lots of limitations, uncertainties, etc. But at least it's a good starting point. Now, it's not really good news for decision makers and payers because it provides, as Anders just said, quantifications of the different population and the magnitude of the population concerned when you consider, and this is the first time it's to me it's so clear actually, when you consider especially the preclinical stage, you know, gives you some sort of a headache. How are we going to tackle such big population? Now, the payer will be concerned, I think, as long as we do have, I mean, the issue of tackling with screening and referring populations, etc., comes when you have solutions to offer. I think that it's only, unfortunately, and we have lots of experiences in that field actually, it's when you have a really effective compound which comes on the market that it crystallizes the need to really assess what is the target population, what would be the budget impact, where lies the value, and how we can make it affordable. Now, I think it's a great opportunity, as it was said, to have those data, which are opening many doors for further research, because we need to be more precise in the different segments. And I think that payers should be careful to make sure that the appropriate research is performed as soon as possible to go further into the knowledge. We mentioned already the biomarkers, and how do you have access to those biomarkers, and what, you know, some are really resource consuming, some are can be harmful for patient. How do you use blood test, which would be probably the first steps to have accessible and non-harmful ways to identify this population, and then if you have them, how you should pay for them, for which type of population. I think that there is certainly more research to make sure that at least you target the people most at risk, and socioeconomics, education, you know, sleep disturbance. I mean, there is a number of factors that should be investigated further to try to control which population should be screened, addressed, referred, etc., so that you can set up some cost-effective strategy to provide access to the appropriate treatment. And from a payer perspective, and depending upon the country system, it may refer to different budgets. What is important, I think, is to outline this very, very large population. It's about 10 times the AD confirmed population that is at risk. Of course, we don't know exactly what are, and this is another area for research with some pieces of evidence, but not really sufficient to understand better what is the real proportion of this population at risk, asymptomatic, etc., that will turn into real AD. I mean, this is a big question to address, because this is what you need to scale detection, screening policies, etc. But then we know that there are already some ways and some means which have been proved effective for this population, which are not pharmacological treatment, which are supportive intellectual, physical activities, etc. And I think this is something that should be looked at also, maybe from different budgets perspective, but which open doors for more consistent and systematic actions. That's my comment. My last comment is that given the magnitude of the population, and even if we stick to the prodromal segment of the population or MCI population combined, I think the price, of course, would be a key question. To me, given the size of the populations, it's something in between COVID-19, you know, addressing all the elderly population, and hypertension, you know. And when you look at prices for secondary prevention for HTA, for hypertension, for instance, we are not in the zone of prices that you would have usually for these highly sophisticated biotech products we're talking about. So there is, you know, a huge issue there that should be probably addressed between payers and companies, etc., before we come to the market. And we have this experience already with Alzheimer in US, where there is so much to learn from. That's my conclusion as a payer.
Yeah, well, thank you very much. The you know, and the idea that these conversations should be happening earlier is really the thrust behind PAVE. So many important pieces in there. The lack of treatments. Hopefully we're on the cusp of new treatments, and as you mentioned, both pharmacological and non-pharmacological. And so hopefully we're getting close to having some breakthroughs. And then the idea that it's the right intervention at the right time for the right duration for the right person. I mean, these are incredibly important themes. I want to move on to Lydia Landman, but before I do that, I want to go back to Anders and Weijia. And just, we've heard a lot about what these results mean, and just want to go back to you and see if you have additional thoughts to put onto the table. Let's start with Weijia.
Yeah, thanks. So what I think that we're moving towards, all of us together, is towards the earlier stages, because ultimately we want to stop Alzheimer's disease to prevent dementia. And the study now done is, I think it really reads like a research agenda, and it sparks so much novel questions that we still need to answer. And I think very in line with what Annie has been saying is that when we think about future with disease modifying treatment, we really focus on the symptomatic stages now. So it's really about these prevalence numbers for biomarker positive patients with MCI and mild AD dementia. And we will really, in these symptomatic stages, biomarker-based diagnosis will become more general, more often being made. And that we need to perhaps funneled diagnostics, first a blood test, followed by CSF biomarkers or PET scan when necessary, to keep this affordable. And then I think one of the largest questions we have for the more lifestyle interventions, primary prevention strategies, non-pharmacological strategies, is whether these are effective still in the stage of preclinical AD, or that you are too late then. And I don't think we have the answers yet. And that will be so interesting, whether you are actually able to still preserve your own brain health when amyloid has started. And that would be is a very relevant research question to answer in the coming years.
Thank you. Anders.
Thanks, Drew, and thanks, Annie and Weijia. I think they're great remarks, and I also agree on the sort of size of the problem. And coming back to our study, I think what we show here is that the numbers are larger than expected, at least than what I expected. I mean, we have seen the prevalence figures before, perhaps, but we haven't really turned them into numbers. And I think it's important for policymakers to do that exercise. And our studies show that it might be, if we look at early AD, which is a target population in many drug trials, we may look at something like 15 million Europeans that could be eligible for treatments. Then you need to deduct contraindications, and of course, not all will show up for care and so forth. So the numbers will come down, but still, it's probably too great of a number to treat anytime soon, right? Even if you have a effective treatment available and approved in Europe. So I think this would be more about identifying those smaller populations, smaller subgroups within this larger early AD cohort that would benefit the most from treatment. One aspect that I think also our study shows is that within this early AD group, in trials we usually see something like half and half mild dementia, mild AD dementia, and half MCI, or even more in mild AD dementia. But if you look at the numbers that we estimate, 80% are MCI and only 20% are mild AD dementia. So that also needs to be reflected when you look at the potential efficacy of the treatments. If there is a difference, there should be a difference, maybe not in the sort of response to treatment, but in the consequences of treatment. If you start in early MCI or if you start in late mild AD dementia. I'm not sure if there's evidence to prove it, but most would suspect that there would be a difference. So I think that is also an important thing to have a watch on.
Right. And now let's turn to Lydia because it's a really nice segue, Anders. So Lydia, just as brief introduction, she's an executive at Roche, but she's also a former government official. She was one of the key leaders in setting up PAVE. So Lydia, I just want to turn this over to you for your perspective on what these results mean for policymakers. And we've heard some of the implications, but if you could elaborate on that, that would be great. Over to you.
Great. Thanks, Drew. So what we actually see is governments and policymakers really aiming now more than ever to develop kind of evidence-based or evidence-informed policy. So this study not only has established a new evidence base related to the number of people living with Alzheimer's disease or at risk of developing in the future, the numbers really related to the prevalence across the different stages of disease really, for me, point towards some great opportunities or areas where governments can take some meaningful action. So I just wanted to kind of really highlight a few specifically. I think first and foremost, and I know this is likely kind of a no-brainer for those of us who kind of work in AD, but this study really proves the case yet again for the need for governments to prioritize action on brain health and Alzheimer's disease. And this is particularly acute in Europe, where the European Commission has not made any commitment to or strategy for AD. And for EU member states, there's really an opportunity to drive the adoption and implementation of national AD plans, making sure those plans are comprehensive and ensuring there's funding dedicated to allow the plans to actually be implemented. So net-net, AD really needs to be back on policy agendas. And I think these numbers really kind of hit that home. Secondly, the fact that we found that the most significant prevalence numbers are amongst those people who have yet to develop symptoms, so in the preclinical, are at risk of developing the disease later on, really creates this incredible opportunity for governments and other public health officials to really double down on efforts aimed at public health education, awareness, really focusing on risk reduction and prevention of Alzheimer's disease, which I think Weijia, Annie, and Anders all alluded to as well. And we know that investing in public health generates better, sustainable health outcomes. It drives economic and social benefits. And really, at the end of the day, this could really help people with Alzheimer's disease to delay the need for care support for as long as possible. And the next piece I'm thinking about when reflecting on the results is they can really help inform where governments and health system planners need to prepare and invest to ensure people living with AD can access the care they deserve now and into the future. And the opportunity to delay the decline of those affected by AD lies really in identifying, diagnosing, and treating earlier than is common today. And yes, it's not going to happen overnight, but this does require funding for sustainable care pathways and really addressing what we see as a high level of variability in diagnostic capacity and access to advanced diagnostic tools. And in particular, there's really kind of a needed investment to increase healthcare system capacity to detect the disease early, and also ensure there's timely access to biomarker-based confirmatory diagnosis. So this really gets at the heart of ensuring that if you want to intervene earlier, where we are kind of seeing the science going and the benefit and the value, you need to be able to kind of get your disease detected early and also have that confirmed via a biomarker. We've seen such incredible progress in terms of innovation related to the tools for detection and diagnosis, but we're still seeing many people wait even up to years to receive a diagnosis. For me, this is really a clear opportunities for governments to have an impact and really to prepare for kind of a future for AD detection, diagnosis, treatment, and care. But all that planning and that investment really needs to start now. And one last area I wanted to kind of highlight is really related to the higher prevalence amongst women who go on to develop Alzheimer's disease. And we heard from Weijia and Anders that this isn't just a result of an older population or women living longer. And this is really on top of what we know about the impact of Alzheimer's disease in terms of caregiver burden. So with women providing the majority of informal care for people living with dementia, this is really accounting for over like 70% of care hours. So here there's an opportunity for governments to ensure that sex and gender differences are reflected and integrated within Alzheimer's policy when they're developing and designing programs aimed at disease awareness, prevention, risk reduction, as well as the development of other health and social care supports. So for me, there's, the numbers can be daunting, but I think once you dig into the numbers, particularly amongst the different stages, there's some really clear kind of opportunities for some policy wins by government.
Thank you, Lydia. This has been a great discussion. We're going to have to conclude here, but before we do, Anders, as the lead author on this study, I just want to close with one question to you. Where do we go from here? What do you see as next?
Well, thanks for that question, Drew. I'm happy to tell that we have continued to work on the next step of this. And we're looking now at Sweden as an example and diagnostics and the diagnostic process of Alzheimer's disease, and look at the preparedness in Sweden for being able to implement new methods. And if we have a disease modifying treatment, what happens then with the funnel, with the patient workup, and how we triage patients through the systems, and what is needed in terms of investments to make treatment available to those that are eligible. So we will present that work now in Lausanne in November, and then a subsequent manuscript for publication, hopefully.
Well, thank you. A big thank you to the panelists. Thank you to Alzheimer's Europe. The conference theme of building bridges, I think, is the perfect sentiment for the world we live in today. As you heard from our experts, hopefully we're giving you some of the foundation for the bridge and the data we need to advance the fight against Alzheimer's disease. If you want to continue to follow the developments of PAVE, we hope you'll follow us on social media. Follow us on LinkedIn specifically, and you can also go to paveeurope.com for more information. So thank you all very much, and I hope everybody has a great day.